Dr. Khalid, it's a great honor for me, considering me a friend, it's a great honor, your friendship, of course. I'd like to thank Dr. Khalid Al-Affaz, Dr. Muhammad Fawzi, Dr. Wissam Mustafa for inviting me today. Today I'll be talking about the role of intervention radiology in the management of pelvic varices in general in females. Here are my objectives. So to introduce, chronic pelvic pain, as Dr. Khalid said, he will save a lot of time in my talk, is assumed to affect approximately 30% of all females in childbearing period, and it accounts for almost 20% of outpatient gynecological appointments. They are actually very common in both young males and females, and pelvic varices are the commonest cause of pelvic pain in females in childbearing period. And it is assumed to be about 40% of Paris females suffer from pelvic varicosities. So the diagnosis, of course, Dr. Khalid covered this very well. I'm only going to say that sometimes this patient might represent with very weird, and this is actually not uncommon, it's common, weird symptoms like continuous genital arousal, hip pain, bladder irritability. So you have to take in consideration all this. Dr. Khalid talked about everything else about the imaging and this stuff, so we will go directly to the technique. So what about the tools you need to do a case of pelvic congestion syndrome? Actually, a 6 French vascular sheath, a curved catheter. It depends on your personal preference. I personally prefer the Cobra from when I'm going from upside, and I prefer either Cobra or Simon when I'm going from the femoral. And microcatheter are very rarely used, and hydrophilic guide wires. So what about the axis? We have 3 possible axes. The first is the jugular. This is my personal favorite. It is very easy to do. You can access both veins very easily, the right and the left. It needs no special tools at all, and very fast ambulation, only compression for 2 minutes. However, it can very rarely cause bad complications like pneumothorax, carotid puncture, etc. The antecubital or the basilic, now it's a new era, the basilic vein. You can also access both veins easily, and it is the safest. However, it needs special long sheaths and catheters, and it needs more skills. Our friends in Saudi Arabia love the arm access. As for the femoral, it is the easiest and the safest, and it is very easy to access the left vein. However, it is very difficult to access the right gonadal vein from the femoral axis, and you need to keep the patient for 1 hour or so with you after the procedure. So actually, I only do femoral when there is a wide downward curve between the renal vein and the IVC like this. If we have this very steep curve, this is a case of circumaortic renal vein. I always do femoral access for these cases. So how to catheterize the right gonadal? Actually, it is very easy. You go 2 to 3 centimeter above the level of renal vein. Here we can see I am writing catheter people versus wire people. The intervention radiologists are divided into cath people and wire people. I believe that you should always learn both. Most of the gonadal and vein catheterization from above, you need to use the wire. However, you need to learn both. Here we can see, we just make the patient do Valsalva maneuver. We are 2 to 3 centimeter above the renal vein. And when the patient does the Valsalva, you are literally inside the left gonadal vein. It usually takes from 3 to 10 seconds to catheterize the left gonadal vein. It's very easy. Now we can see in slow motion. Then we'll make the patient take a deep breath or do Valsalva maneuver, and you are in. Okay, so the right gonadal is actually very difficult. So you have to identify the right renal vein, go about 1 centimeter below the right renal vein, and direct the catheter laterally, and then manipulate the wire anteriorly. Here we are also using our wire. So we can see here we are in the IVC. The catheter is lateral and the wire is anterior, and you are in the gonadal vein. I'm showing it in slow motion. You have to get your catheter to the right side, as you can see here. Now I will take the wire up. We are in the IVC now. The catheter is lateral, and the wire should look anterior, and then you are in the gonadal vein. However, this is not always the case. Sometimes you keep on doing this maneuver, and you can never find the right gonadal vein. So in these cases, you have to go and look with your catheter. You want to catheterize it as if you are catheterizing the artery, as if you are working in a chemoembolization catheterizing the celiac. Because as one of these examples, I have so many examples like this, but we can see it is looking totally medial, not in the direction, and it has a very low-lying gonadal vein. So in veins like this, you cannot just do it with the wire. So you have to learn how to use the catheter properly and to use the wire at the same time. So what about embolics? We have so many embolics that have been used in this. The coils are the most widely used worldwide because money is not an issue. It is very easy to deploy and safe. However, it doesn't fill the tributaries and anastomosis. Sometimes it does very proximal embolization if it is done our way in Egypt to save money, and you need a lot of coils, which is very expensive. Otherwise, recurrence rate is very high. Migration is very rare. Here are some cases with coils. You can see I put 3 or 4 coils. In Europe and America, they usually put maybe 10 or 12 coils. So after coils, I shifted totally to glue. Glue can fill all the anastomosis and tributaries. It is very durable, no recurrence at all, and it is very cheap. However, it is difficult to handle, but we can handle it. It doesn't go very distal, and it is inefficient in larger veins in females. It doesn't go very distal unless it is diluted to 1:4 or 1:5 glue to lipiodol. It causes phlebitis. However, this is not a big issue, but about the safety, here is how I prepare. This is my way to prepare the glue. I put the lipiodol first, then I put the glue in, I mix it, I put a line of dextrose before injection, then I inject my glue, and then another line of dextrose, and get it out fast. So things are good. I did lots of cases with glue. It's very good. As you can see in this image, it is filling all the tributaries. It's not, everything is fine. I've used glue for years. However, sometimes I remember this patient, the patient just coughed, and we can see here there is massive pulmonary embolism. When the patient coughed glue, I've seen the glue traveling through the IVC to the lung, and I was about to faint. The patient then started to cough. Actually, and then nothing happened, but he had to take anticoagulation for a month afterwards in a very elective procedure. So actually, I now save glue for very special cases, and I shifted to polydecanol foam sclerotherapy. Foam sclerotherapy, it can fill all anastomosis and tributaries. It can be injected very distally in the varices. It is very cheap. However, it has the highest recurrence rate. This is, you all know, the Tassari method, how to prepare the foam. I prepared one polydecanol 3% to 4 room air and mix it like this. And actually, it was going amazing, but I used it for years, but recurrence was high. It was not very high. Actually, it's not in all the patients, but maybe 20 to 25% of patients came back as if they did nothing. So I shifted to the sandwich technique, the foam plus coils. This can fill all the anastomosis and tributaries by foam, decrease the recurrence by coils, and it is very safe. Still, if you use many coils, it is very expensive. As you can see here, these are cases with coils and foams. However, actually, my dear friend Muhammad Al-Muaqqal from Saudi Arabia taught me a very nice technique, which is the uncoiled coil technique. As you all know, the coils has filaments around. These filaments induce thrombosis. So you can use it. One coil can be used for the whole vein, and it is very good. It can fill all the anastomosis and tributaries and decrease recurrence. And it is cheap because you will only use one coil. However, it can't be done if so many proximal tributaries. Like a case like this, you cannot use it. A case like this, you can see here. Here you cannot put uncoiled coil because there are very many proximal anastomosis or proximal. There are not only one gonadal vein, there are 3 or 4 gonadal veins, so you have to put a coil in each one. So in these cases, I usually go on each one and do glue. So this is how I uncoil the coil because it has a very nice technique. You oversize. I use a bigger size, and then I just keep the wire, keep the coil in place with the wire, and pull the catheter in a rotational direction. As you can see, I'm rotating my catheter to keep the coil. I don't push, because if I push, it will scaffold and take its shape. I don't want it to take its shape like this, and then I inject afterwards more foam around. So what about special techniques? Actually, I thought of things that are very common, so I will not talk about the treatment of Nutcracker and May Turner, because we all know them. So we will see things that are more interesting. The first thing is the technique of distal foam injection. You do not only embolize the gonadal veins, you need to embolize the deep veins. As here we can see, we inject, make the patient do Valsalva maneuver, we inject contrast medium, and then we pull the contrast medium with foam till the contrast medium totally disappears. We should do this slowly because we don't want them to go, we don't want the foam to go to the iliacs. So we do this till we see it is totally filled with foam. A very good question is when to embolize the internal iliac veins. I do this now routinely. I embolize the internal iliac veins routinely. You always check for iliac siphoning, especially in patients with lower limb varicosities. If no siphoning, always check the internal iliac vein. Here, this image shows clearly the siphoning. As you can see here, bilateral internal iliac reflux. So this is, here we do not go to the internal iliac to check it actually. However, if no gonadal reflux in patients with pelvic varices, we should always check the iliac. Here we can see we are injecting, we went also distal, and everything is in the right direction. The patient has pelvic congestion syndrome. So in these cases, we have to check the internal iliac. What should the normal iliac, the very normal iliac, look like? 0% reflux. We ask the patient to do Valsalva, and everything in the right place is going back to the IVC. We can't see anything going downwards. So, in other patients, as you can see in these images, when you inject and the patient is doing Valsalva, the veins are filling into the vulvar and vaginal and pelvic congestion. So in these cases, you have to inject. Here we have an illustrative case. Here we went to the gonadal. I will try to run it quickly. You can see the gonadal. You can see it has huge amounts of vulvar, gluteal, but you can see everything here. We did our regular maneuver. We embolized and we put 2 uncoiled coils, and afterwards everything is good. Then we did the same in the other side. As you can see here, I want to show you this in a better way. It is going down through the obturator. This patient had the 6 leak points. The 6 leak points, it was filling from everywhere. So we injected, we did the same, and it was done successfully. Afterwards, I went for the iliac because the patient had huge amounts of vulvar and gonadal varices, and that was her iliac. So I went into the right. You can see huge. This is the vulvar area and the vaginal area. The patient actually looked like a male in her underwear. It was as if she had 2 small testes. It was heroic actually. And we did it. We will see I embolized with gonadal veins, and here after embolization nothing is going downwards. I went to the other side and we found the same, and I also embolized it with the sclerotherapy. After that, I went and I did direct puncture, which I'm going to show you in other cases. So what about vulvoperineal varices? That's a very important issue. The prevalence of vulvar varices in general population is about 4 to 5%, with or without pelvic congestion syndrome. The incidence rises up to about 40% in patients with pelvic congestion syndrome, and actually we see this every single day. The relevant anatomy, actually, Dr. Khalid spoke about this very well, the leak points, so I'm not going to talk about it again, but the idea is you should always treat the gonadal and iliac reflux first. If you find this and she has also pelvic congestion syndrome, you have to treat the pelvic congestion syndrome first. And then afterwards you go and treat it either by surgical ligation, which is not a very common procedure, or sclerotherapy, which can be done ultrasound guided, as Dr. Erica says, which is the classic, or our new combined ultrasound fluoroscopy technique. So what is my technique for treatment of these? Patients with, first of all, the anesthesia. It's a very sensitive area. So if patients has planned vulvar punctures, you should should do ultrasound guided pudendal nerve block of the affected side. It's very easy. You can see the neurovascular bundle easily and inject it, infiltrate it with about 4.5 milligram per kilogram body weight. However, if patients need only perineal, gluteal, or inguinal punctures, only subcutaneous lidocaine would be sufficient. I use 2% etoxysclerol. Now I'm shifting to the 1%. They are both good. You need an 18 gauge cannula, and you can inject it. Here is a procedure for a whole case. Here we can see this is the vulva of the patient. We can see there are so many varicosities. You try to go as low as possible to feel as much as you can. Here is magnification and puncture of the vulvar varix. And then you take an venogram, as you can see here. Here we are injecting to see what kind of leak points this is filling. This was actually filling most of the leak points. You can see this particular patient came suffering from continuous genital arousal. She feels always heat in her vulva, and her vulva was swollen. Now we do prepare by the Tassari method. And then we inject in a pulsatile, very slowly motion, and we push, as we can see, the contrast medium, as we can see here, the contrast medium, and we are pushing the contrast medium till we fill the whole thing. And then afterwards, we can see there is nothing going, and we do the same for the other side, of course, but to save money. Here, this is very important for the post-procedural care. You see here in this is the ultrasound after injection. We have to do very good compression for about 5 minutes after we finish, and instruct patient to wear tight underwears for 1 week and apply hot fomentation for 3 days. Patients can be discharged directly after the procedure, no specific medication. Please, if you have time for 1 minute, I will leave this. You can scan. This is my recently published papers in our first 70 patients. Now we have 150 patients. I did it with my dear colleague, Dr. Rana Tariq. So if you have time to scan this, it is for free, and it has everything about this procedure. Unfortunately, I believe my time ended. I wanted to talk more about this particular subject because we did some good research about it. Here we can see in these pictures all the leak points. So thank you very much. No? We have أنا مش مكملها على أساس إنها ربع ساعة. أنا أخدت فيها زيادة بس.